Cervical fascia. Cervical fascia, fascia of the neck is divided into superficial and deep cervical fascia. Superficial cervical fascia is simple, whereas deep cervical fascia is generally divided into investing, pretracheal, and prevertebral fasciae. It's interesting to note that some specialized areas of the deep cervical fascia assist in forming subcomponents of the deep fascia. Cervical fascial clefts are those spaces between fascial layers that may permit the invasion of infection even into the thoracic cavity, leading to grave results. Fascia represents thickened condensations of fibroelastic connective tissue that surround and separate movable structures of the body from each other. This would include certain bony joints, individual muscles, muscle masses, and certain neurovascular components. Spaces between layers of the fascia are occupied with loose connective tissue that may permit the quick and easy spread of infection from one area to another. Thus, it is important for the clinician to be familiar with the locations and connections between fascia, and the intercommunications between fascial spaces. With this knowledge, the clinician may be able to prevent the spread of infection and develop a sound therapeutic program of treatment. Fasciae of the face and deep face are continuations of the cervical fascia as it proceeds over the mandible and onto the scalp. The fascia of the face possesses superficial and deep components with many subdivisions. The many facial layers and subdivisions of the fascia share facial spaces and clefts, which makes the face and deep face an easy target for the spread of infection from one area to another and, if improperly treated, perhaps eventually into the thorax. Clinicians must be fully aware of how infection may be spread in and about the face, deep face, and oral cavity. Facial names are frequently controversial because of their varied thicknesses, described limits, attachments, and interrelationships. Moreover, various authors are in disagreement and may assign different names to the same facial layer. The student has to learn to live with this and, with some extra study, may be able to distinguish one name from another. Fascia and facial spaces presented in this chapter are categorized based on boundaries and communications so that names will be less confusing to the clinician. Fasciae are thickened condensations of fibroelastic connective tissue that separate various movable structures from one another. Spaces between layers of fascia are filled with a loose type of connective tissue that permits infection to spread from one locale to another with relative ease. Because infection may travel along these fascial sheets, the clinician should possess a working knowledge of their locations, extent, and intercommunications. Armed with this knowledge, one can anticipate possible complications that may arise from the various procedures that were performed and develop a sound therapeutic program for their prevention and treatment. Because fasciae are merely sheets of connective tissue of various thicknesses, considerable controversy surrounds their limits, attachments, and interrelationships. Compounding these problems is that different authors frequently assign different names for the same facial layer or suggest that some of the flimsier connective tissue sheets do not deserve to be classified as fascia. The goal of this chapter is to present fascia and facial spaces from a standpoint of boundaries and communication so that varying terminologies will be less confusing to the clinician. Cervical fascia, fascia of the neck, is subdivided into superficial and deep cervical fascia. Facilitating movement unlike that in its thick, attached posterior region. Superiorly, the superficial cervical fascia passes into the head posteriorly, and over the mandible and parotid gland anteriorly to cover the face and skull. The muscles of facial expression as well as nerves and vessels that serve these structures are located in this facial layer. The superficial fascia is separated from the deep fascia by a facial plane permitting free movement of the skin in this region. Deep cervical fascia. Deep cervical fascia is generally described as composed of three layers: investing, pretracheal, and prevertebral. The deep cervical fascia is, for descriptive purposes, usually divided into three layers: investing, pretracheal, and prevertebral, although this is not a completely accurate division. Actually, several other named facial layers are of anatomic and clinical importance in the cervical region. Investing fascia, known also as the superficial or anterior cervical layer of the deep fascia, surrounds superficial cervical fascia. Superficial cervical fascia, since it surrounds the neck, is cylindrical in shape. The platysma muscle, located in the anterior portion of the neck, is contained within this fascia, as are some of the superficial nerves of the cervical plexus. The fascia of the neck is subdivided into superficial and deep layers. The superficial cervical fascia, tela subcutanea, surrounds the neck in a cylindrical fashion. It contains the platysma anterolaterally as well as the cutaneous branches of the cervical plexus. Inferiorly, the fascia is continuous with that over the pectoral and deltoid region anteriorly, and posteriorly it blends with the fascia over the back, where it becomes firmly attached to the deep fascia. This thin fascia is freely attached anteriorly, thus the neck as a cylinder covering the anterior and posterior cervical triangles and investing the muscles forming the boundaries of these triangles. This fascia arises from the spinous processes of the cervical vertebral column and ligamentum nuchae, and then encircles the neck. As it passes anteriorly, it divides into two laminae enveloping the trapezius muscle. The two layers unite before crossing over the posterior cervical triangle to form a single, thickened sheet. While there, it splits to surround the inferior belly of the omohyoid muscle and forms a ligament that fixes the intermediate tendon of that muscle in a constant position relative to the clavicle. At the posterior border of the sternocleidomastoid muscle, the investing fascia divides once more to encompass that muscle. The two layers fuse again at the anterior border of the sternocleidomastoid before passing superficial to the anterior triangle as a single layer. As this fascia encounters the suprahyoid muscles, it envelopes each muscle with a thin fascial covering that is attached to the mandible superiorly and the hyoid bone inferiorly. As the investing fascia leaves the hyoid bone, it envelops the infrahyoid muscles, surrounding each muscle with a thin fascial covering. Inferiorly, the fascia is attached to the acromion of the scapula and the clavicle. Subsequently, the investing fascia divides to become attached to the anterior and posterior surfaces of the manubrium, creating a space between the two layers known as the suprasternal space. This space usually contains the jugular arch, a venous connection between the two anterior jugular veins, and an occasional lymph node embedded in adipose tissue. The superior extent of the investing layer of the deep cervical fascia attaches to the external occipital protuberance, the superior nuchal line, and the mastoid process of the temporal bone. Here it splits to enclose the adjacent parotid gland and continues superiorly as the parotid fascia. The superficial lamina of the fascia attaches to the inferior margin of the zygomatic arch, and the deep lamina continues along the temporal bone to the carotid canal. It is from this deep lamina that the stylomandibular ligament is formed, coursing from the styloid process to the inferior border of the angle of the mandible. Thus, this ligament effectively separates the parotid from the submandibular gland. Although the anterior and external jugular veins appear to course between the superficial and deep cervical fasciae, they actually course within the superficial layer of the investing fascia. Pretracheal fascia. Pretracheal fascia, or middle layer of the deep cervical fascia, encases the trachea, esophagus, pharynx, larynx, and thyroid gland. Because most of the viscera of the neck is encased by this layer, it is sometimes referred to as the visceral fascia. The thin, filmy anterior lamina of this fascia lies deep to, but makes contact and blends with, the deep layer of the investing fascia covering the infrahyoid muscles. Because of this intimate relationship, the pretracheal fascia is sometimes described as being derived from the deep layer of the investing fascia. The remainder of the pretracheal fascia completely invests the thyroid gland, and its deeper layer encircles the larynx and trachea as a tubular structure while being well developed on the pharynx and lateral aspects of the esophagus as the Buccopharyngeal Fascia, thus separating the esophagus from the prevertebral fascia. On covering the superior pharyngeal constrictor muscle, the Buccopharyngeal Fascia continues laterally over the buccinator muscle and attaches to the pterygoid hamulus and pterygomandibular raphe and is attached superiorly to the pharyngeal tubercle of the occipital bone. The portion blanketing the medial pharyngeal constrictor muscle continues anteriorly, with the pretracheal fascia covering the hyoglossus and genioglossus muscles. Additional superior attachments include the hyoid bone and the stylohyoid ligament. Inferiorly, the pretracheal fascia begins with the oblique line of the thyroid cartilage and descends to merge with the fascia covering the aorta and the fibrous pericardium and to the fascia of the posterior thoracic wall. Prevertebral fascia. Prevertebral fascia, the third major layer of the deep cervical fascia, encases the layers of musculature about the vertebral column. This fascia is described as originating from the ligamentum nuchae and the spinous processes of the cervical vertebrae. It covers those muscles of the back that extend the neck and, therefore, lies deep to the trapezius muscle and the investing fascia. Laterally, it blankets the scalene muscles and then turns medially to attach to the transverse processes, where it splits, forming a double lamina that fuses with its two layered counterparts of the opposite side. In its position, it forms the floor of the posterior cervical triangle. Superiorly, it is in contact with the investing fascia covering the trapezius muscle. Inferiorly, this fascia continues into the thorax to cover the muscles of the neck as they insert into the rim of the superior thoracic aperture. A fascial space is evident in the posterior triangle housing the accessory nerve and a few lymph nodes. Near the base of the posterior triangle, the fascial space is enlarged as the prevertebral fascia passes over the scalene muscles. This permits passage of parts of the subclavian and external jugular veins, the transverse cervical and suprascapular vessels, supraclavicular and suprascapular nerves, and the inferior belly of the omohyoid muscle. As the roots of the brachial plexus emerge from between the anterior and middle scalene muscles, the prevertebral fascia is reflected onto them, which blends with the axillary sheath. In covering the anterior scalene muscle, the fascia also overlays the phrenic nerve as it courses superficial to that muscle on its way to the thoracic cavity. In addition, as the prevertebral fascia approaches the anterior tubercles of the vertebrae where it attaches, it also contributes to the formation of the posterior portion of the carotid sheath and covers the cervical sympathetic trunk. In continuing on its medial course from the anterior tubercle, the fascia splits into two laminae as it crosses the midline immediately deep to the buccopharyngeal fascia of the posterior visceral wall. The anterior lamina is called the alar fascia, which blends laterally with the carotid sheath and is loosely attached in the midline to the buccopharyngeal fascia. The alar fascia fuses with the buccopharyngeal fascia at about the level of the seventh cervical vertebra, or it may continue into the thorax before fusing with the visceral fascia. The posterior lamina, lying against the body of the vertebrae, remains known as the prevertebral fascia. Thus, the space formed between these two laminae is referred to as the danger space or space 4, not to be confused with the retropharyngeal space, which is discussed later. The danger space is continuous from the base of the skull through the neck into the thorax, to end at the diaphragm. Carotid sheath. The carotid sheath surrounds the common carotid artery, internal jugular vein, vagus nerve, and the internal carotid artery. The sheath is composed of contributions from the investing and pretracheal fasciae. Its posterior wall receives contributions from the investing fascia, thus completing the cylindrical sheath. The fascial covering that surrounds the common carotid artery, internal jugular vein, vagus nerve, and internal carotid artery is the carotid sheath. This cylindrical structure lies between the investing and pretracheal fasciae anteromedially and between the investing and prevertebral fasciae posteromedially. The anterolateral portion of the sheath is formed by the investing fascia, with some contribution from the pretracheal fascia. The posterior wall is derived from a medial lamina of the investing fascia, thus, the medial wall of the sheath is formed as the two leaves of the forming sheath unite. In addition, the medial wall of the carotid sheath is attached to the prevertebral fascia. Superiorly, this sheath is attached to the skull around the jugular foramen, and inferiorly it is continuous with the fasciae of the great vessels and heart. The interior of the carotid sheath is compartmentalized to separate the arteries, vein, and nerve. Fascial spaces and clefts in the cervical fascia are important to the clinician because they can provide passageways for the spread of infections. Potential spaces, and facial clefts between facial layers and the structures they cover are of clinical importance because they may afford passageways for the spread of infection. Although many of these spaces are inconsequential, several are worthy of description. Visceral compartment. The visceral compartment of the neck, as the word implies, refers to the viscera of the anterior neck, which includes the thyroid gland, trachea, esophagus, the pharyngeal constrictor muscles, bounded anteriorly by the deep layer of the infrahyoid and pretracheal fascia, part of the carotid sheath, and posteriorly by the Buccopharyngeal Fascia. The visceral compartment of the neck includes the area bounded anteriorly by the deep layer of the infrahyoid fascia and the pretracheal fascia surrounding the thyroid gland, trachea, esophagus, and pharyngeal constrictor muscles, laterally by the medial portion of the carotid sheath, and posteriorly by the Buccopharyngeal fascia superiorly, blending with the visceral fascia inferiorly. The anterior portion of this compartment surrounding and anterior to the trachea has been termed the pretracheal space, whereas that posterior to the trachea and surrounding the esophagus posteriorly is termed the retrovisceral space, often referred to as the retropharyngeal space. The retropharyngeal space is continuous inferiorly, caudal to the pharyngeal constrictors, with the retroesophageal space. Thus, the term retrovisceral space is the more accurate and inclusive term. Danger space. The danger space extends from the base of the skull to the diaphragm and is a closed space. It appears, therefore, that infections located in the danger space result from infectious dissections through the alar fascia from the retropharyngeal, retrovisceral, space. Therefore, this space is of particular importance to the clinician because it is the pathway for the transmission of infections from the head and neck into the mediastinum. Spread of infection via this route can be life-threatening. Masticator space infection. The deep fascia splits at the mandible, forming two laminae around its inferior border. As a consequence, the muscles of mastication, the temporalis, masseter, medial and lateral pterygoid muscles, are thus enclosed by a compartment termed the masticator space. The two laminae of the deep fascia fuse again at the superior border of temporalis muscle where it originates from the skull. In addition to containing the muscles of mastication, this large space also contains the maxillary artery and many of its branches, and the mandibular division of the trigeminal nerve and many of its branches, as well as much of the buccal fat pad. The masticator space also communicates with many other spaces within the head and neck, which may contribute to the spread of infections and/or neoplasms from the oral cavity. Salivary gland tumors, abscesses, hemangiomas, and metastatic extensions of squamous cell carcinoma, especially from the floor of the mouth, tonsillar fossa, and nasopharynx, can extend into the masticator space. Persons suspected of having masticator space infections are very ill and need immediate medical attention.